go ahead and start. Thanks for coming out today. We're going to be talking about evaluating and preparing the ocular surface prior to surgery. You know, dry eye and the ocular surface has become a big topic, so big that if you'd have told me years ago that Forbes was going to do a whole article on dry eye treatment, I would have shaken my head and said, no way. But you can see I was interviewed by Forbes, and we talked about how to treat dry eye. And it turns out, in talking to the writer, her and a bunch of her friends have dry eye. So this is becoming, dry eye and ocular surface disease is becoming a very common topic. You could actually say it's even an epidemic. If you go to China, doctors are reporting 80% of the patient population has dry eye. I'm seeing in my clinic at least 50%. Now, I think I'm going to be talking about treating ocular surface disease, but I think half the battle is lifestyle choices and diet, and that's why I wrote a second book. This is a continuation of my first book on dry eye disease treatment called the Toyos Dry Eye Diet, where I basically, what I'm doing with my patients, I'm putting them on a 2-month starter diet to clean up their gut bacteria. We now know that if you have an acidic gut, you're going to be in an inflamed state. And the only way that you can really change that gut bacteria is with diet. Probiotics have never been shown to change an acidic gut. You have to actually talk to your patients about changing their diet. And I have a specific diet that's worked countless times in changing an acidic gut into a good gut. It also has a bunch of information on the latest dry eye treatments, what I see in the future, how we're treating this disease. Has a lot of lifespan technology, blue zone information to help our patients. And I think this is an unmet need in our profession, and it shouldn't be. I specialize in cataract surgery, LASIK surgery. Actually do more SMILE than any type of other laser corrective procedure. And I'm a dry eye specialist. So we're very attuned in our clinic to spotting ocular surface disease. But when I go around and I talk to surgeons, the main thing that they tell me is they don't really have a lot of time to do diagnostic work to figure out if their patients have dry eye disease or not. So that's why I worked with Oculus on a research project on, is there things that we can do with the Keratograph 5M to figure out if quickly, diagnostically with technicians, to figure out quickly if a patient has ocular surface disease, and is it so bad that we need to treat beforehand. Now, why is this important? It's important because the incidence of dry eye disease in your cataract population could be anywhere up to 70% of the population. And nowadays, I used to just talk about cataract surgery, but I'm finding with young people, I would say 30% of our LASIK refractive population have dry eye as well. It used to be my dry eye clinic was a bunch of 40-year-olds and above. 50-year-old females and above used to be the majority. But now we're seeing 20-year-olds. I've got teenagers with this. And why is this happening? Because of lifestyle choices. These kids are on their phone all day, they're on their computer. 2 out of my 3 daughters had dry eye disease during their teenage years. One, they weren't eating right. They weren't eating what I was eating. They weren't eating right. They were on their phone constantly. If they weren't on their phone, they were on their computer watching Netflix. Or if they weren't doing that, they were doing homework on tablets. Your blink rate, when you're just sitting there normally, is 15 blinks per minute. When you're on one of these devices, it's 4 blinks per minute. And what we're finding is we're training our brains to blink differently. So even when you're not on your device, you see people and they're just sitting there and they're not blinking because they're so used to looking at a device. So if you're not screening for ocular surface disease, you're missing a big percentage of your patients. So I have the corneal confocal microscopy, and what I'm finding with corneal confocal microscopy is that even mild dry eye disease is causing changes in the cornea. So a lot of doctors tell me, well, I don't really need to treat mild disease. And that's not the case, because we're seeing that this is causing changes in the cornea, whether you have mild, moderate, or severe disease. And if you have changes in the cornea, that's changing the tear feedback loop. So basically, we have nerves in our cornea telling our brain to produce a tear. And if those nerves are destroyed, then we have an abnormal tear being produced and not produced at the normal rate. Tell me, well, my incision is so small, it's not disrupting anything on the ocular surface. And now we know with corneal confocal that's not true. This is actually a small incision cataract surgery patient. And what do you see there? On the slit lamp, you see absolutely nothing. But on the confocal, you see that that incisional scar is causing those nerves not to come together. So this is disrupting that corneal nerve feedback loop to produce a tear. So if you're not treating mild dry eye disease and you're doing surgery, this is what can happen. So when these patients are complaining post-surgery, oh, my eyes don't feel right, I feel dry, this is what's going on. So how can we use the 5M, the Cataract? So what we decided to do is put patients through that were coming for surgery, whether they were having refractive or cataract surgery, and we're doing the full battery of tests, looking at their tear film quantity, quality, the meibomian gland, doing meibography, looking at redness. So instead of doing a Schirmer's test, we don't do Schirmer's unless we're doing a research project. We look at tear meniscus. Now, what's confusing to people, and it's confusing to doctors and patients alike, is they have dry eye, but they say their eyes are watering. And this is what's happening. If you don't have your normal fatty layer, what your body does is it responds by telling the lacrimal gland to make more water. So one thing I look at with the tear meniscus, if somebody has meibomian gland dysfunction and their tear meniscus is low, abnormally low, it tells me there might be not only a meibomian gland dysfunction, but a lacrimal gland dysfunction. So if you have a patient with meibomian gland dysfunction and they have a low tear meniscus, that's a sign that they might have dual mechanism dry eye disease. So this is how we use tear meniscus instead of using a Schirmer's test to see water production. And then we do non-invasive tear breakup time, tear film dynamic. We look at the lipid layer, and then we look at conjunctival redness. And for some dry eye patients and ocular surface disease patients, this is the biggest problem. So I had a CEO of a billion-dollar company, and he had dry eye, but his biggest complaint was how red his eyes were. So he would walk into a meeting, and everybody would go, oh, you had a rough night last night? And he'd go, no, no. Or they'd say, you've been smoking some marijuana? And I'd like, no. And so this is what bothered him the most. So we need an objective way of seeing if the treatments that we're doing is actually helping the redness. And using the Cataract to do this is a perfect way to do this. And we've done some studies using the Cataract in this way. And then you can get an objective score, meibography. Now, meibography is important, and you're going to see in terms of screening. So one of the things that patients don't understand is that meibography doesn't change overnight. If you have a normal meibography, that means that you've had dry eye disease for a long period of time. So I mentioned the confocal before. Confocal shows me what's acutely going on in the cornea with their dry eye disease. What tells me what's going on and what's been happening for a long period of time is the meibography. So the meibography doesn't have these kind of changes where you're getting loops or shortening, corkscrew. That didn't happen overnight. And the other thing in terms of telling patients is this took years to happen. So it's going to take time. So it takes at least 9 months to a year for the meibography to change if you're treating this patient and you're treating them effectively. So I don't use meibography as we did a treatment last week, did the meibography change? This is my long range, are our treatments effective for these patients? And my biography is important too, to have these pictures because, and this is not a procedure that I do, but there's some doctors that are doing probing. And with probing, the concern that you have is, you see those looping meibomian glands? What if you probe and you actually transect those glands by probing? So if you don't have meibography and you're doing blind probing, this could be a problem, because what we're seeing is you can transect these meibomian glands and cause scarring that we can't bring back. So meibography becomes important in that sense. So what is the normal cataract refractive practice that's, not quote unquote into dry eye? That's what some doctors have told me. I'm not into dry eye. I get it. You're a busy cataract practice, you're a busy LASIK practice. So what do you need? You need something that doesn't require a lot of your time, because you don't have the time to sit there with the patients and do all the evaluation. You need something that's tech driven, and you want a quick answer to the question is, does this patient have bad enough dry eye where I have to actually do some intervention before I do surgery? And this is what we looked at in a study. So we had just under 100 patients that were coming in for surgery, no prior dry eye diagnosis in their chart, no prior symptoms where they discussed it with the doctor, and we went through the battery of tests. And what we found in these patients is the two things that were correlated with slit lamp exam in terms of diagnosing dry eye was meibography and non-invasive tear breakup time. So what are we looking for in meibography? If you have 25% loss of meibomian glands or greater, you are going to need interventional treatment before you have your surgery. And or if you had a non-invasive tear breakup time of less than 10 seconds on meibography, whether it's one eye or both, you're going to need interventional treatment. So this is important because let's just take a scenario. I'm a busy cataract surgeon. We're booking cataract patients. They come in, I tell my tech, do the keratograph. So they get meibography and they get non-invasive tear breakup time. This is something that they can look at. Before I even walk in the door, they can tell me, look, patient has greater than 25% loss and has an abnormal tear breakup time of 7 seconds, 6 seconds, and 5 seconds. I walk in, before I even see the patient, I look, they're in that red zone of being abnormal that I'm going to have to do treatment. I talk to the patient, I say, look, Ms. Jones, you have a cataract. We're going to schedule you for cataract surgery, but in our diagnostics, we found that you have dry eye. Have you ever suffered from dry eye disease? And then this starts this conversation because patients, aren't as forthcoming to a technician, but if you just ask them some probing questions, when you're in the car and the air is blowing, does your vision decrease? Do you feel like there's sand in your eye? Is your eye sometimes red? When you're reading, does the vision blur out on you? And then they go, yes, 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 yes. And you go, well, that's dry eye. And before I do any kind of surgical procedure, I know if I want the optimum results, I'm going to have to treat your dry eye disease. So what I've gotten from patients when I do that is they say, these are the responses that I get from them. Oh, I was reading on the internet that dry eye disease was something that goes along with cataract surgery or LASIK surgery. I'm glad you're screening for this. Or they tell me, oh, you know what, I've had this problem and nobody has dealt with it. I'm glad you're dealing with this before we do this surgery. So it's actually the exact opposite of what doctors think. If you talk to them about their dry eye and that you're going to treat it before surgery, they look at you as a more valuable surgeon, a surgeon that's looking out for their best interests. They don't leave. I've never had a patient go, oh, you're going to do dry eye treatments to me. I'm actually going to go down the street and do somebody else. And actually, on the refractive end, on that LASIK SMILE end, I've actually had patients say, yeah, you're the third doctor that I saw. You're the first one that actually even mentioned dry eye and how you're going to treat it and do with it. I'm going to go with you as the surgeon. Another pushback that I get from surgeons is, well, I don't have 6 months to put these patients on drops to take care of their dry eye before I do surgery. Most surgeons are probably going to be like me. You've got a 2-week turnaround time from the time you actually see a patient and book them for surgery. So what do surgeons need? They need a quick treatment that can improve the ocular surface enough for the patient to have their surgery. They can't wait a couple of months on a drop. Maybe that drop doesn't work. So then you try another drop, and then that drop doesn't work. Or a drop's working, but it's not changing the ocular surface quick enough. So we need something quick. So if you know anything about me, you know about intense pulse light for dry eye. That's using wavelengths of light to stimulate the glands to work better. So this is a typical patient that walks into my office. You can see the telangiectasias. You can see the meibomian gland dysfunction. They're making a lot of water because they don't have any fat. So what I tell these patients is we have this treatment called intense pulse light. What I'm going to do is apply these wavelengths of light onto the skin. These wavelengths of light will go to the meibomian glands. Right after I do this treatment, I'm going to express this abnormal secretion from your meibomian gland. We're going to do this treatment now. Then we're going to wait a week or two, do another treatment with expression, and then you'll be booked for your surgery once your ocular surface is normal. And I find 2 treatments with IPL and expression gets a majority of these patients ready for surgery with their ocular surface. So an IPL system that I've been using in 2 of my practices, the one in New York and also the one in Nashville, is the Darwin system, which is Oculus's system. If you don't know about IPL, quickly, it's not a laser. This is a flash lamp. It's producing wavelengths of light anywhere from 400 nanometers all the way to 1,000 nanometers. The wavelengths of light that we want that are actually beneficial for meibomian gland dysfunction and beneficial for dry eye is red. So what we're doing is we're putting a filter on these wavelengths of light to block out all the wavelengths below red. And so we're using the red wavelength, and these wavelengths penetrate the epidermis, go to the dermal layer, and does several things. Red actually can interact with the oxyhemoglobin and telangiectasias and cause coagulation of these abnormal telangiectasias. Red actually is stimulative to the mitochondria of the meibomian gland cells. This process is called photobiomodulation. You're probably walking around in a bunch of different booths who are talking about photobiomodulation to help the retina. This actually lowers the amount of inflammatory mediators on the skin. And we did a study looking at IPL, and it showed that it lowered the interleukin 17 and interleukin 6 on the tear film. So it's decreasing the inflammatory mediators on the ocular surface. So IPL does a bunch of different things. It kills bacteria. We can generate heat in the dermis to melt these secretions so I can express. It closes off the abnormal telangiectasias, which are secreting inflammatory mediators that are breaking down the skin and the gland. And the number one reason why IPL works, it's actually stimulating cells to work better. And that process is called photobiomodulation. So photobiomodulation is used in all sorts of medical specialties. It's used in orthopedics, where they use infrared after surgery on ligaments and tendons and bones. It's used in plastic surgery and dermatology as a way to stimulate the fibroblasts to make collagen and elastin. And it's used now for patients with dry AMD, where they sit in front of a light, and these wavelengths of light stimulate the retina to improve in patients and decrease the advancement of macular degeneration, and we're using it for dry eye. So I like this handpiece. It's very ergonomic, very easy to use. We're actually doing treatments on the upper lid and then from ear to ear, which is the protocol I developed, over 20 years ago, which is a protocol I used for FDA approval of IPL for dry eye. And then for expression, I like the Oculus lid stick. I express about 80% of my patients now. It's just a great way to tell what's coming out of the meibomian gland. So whether they have dry eye or not, I just take an Oculus lid stick out, put some proparacaine or tetracaine in, and I express. So it's got a smooth silicone tip, so you don't have to worry about injuring the conjunctiva or the cornea. It is hard enough that I can press with my finger with using the lid stick underneath the palpebral conjunctiva to express these glands, and I just express these glands one by one and get all of the secretion out. And this is what it looks like after 2 weeks of treatment with IPL and getting them ready. You can really make a big difference, and I'm not sure if this is showing up, but here's a patient with lid thickening, telangiectasias. You could tell that they have an overgrowth of bacteria, and then after 2 treatments, we've improved the lid margin, we've improved the secretion, and this isn't something we looked at, but most of the bacteria that causes endophthalmitis comes from the lid margin, gram-positive, staph, and strep. So we know that when we're doing IPL actually decreases that bacterial load. The Darwin's a very good system, and one of the reasons why is that it gives you the same energy per pulse. And that's important because most IPL systems, what happens is the more you use them, the more the flash lamp decreases the energy it gives you. So that becomes a problem because if you're going to treat somebody and you have a protocol and they're going to need 12 joules of energy, and you treat them this month and they come back 6 months later and now your IPL system is generating 8 joules when you put in 12, it varies on what this treatment is going to be for that patient. So you really want a constant energy level per pulse that you're putting in to the system. So you see now there's a lot of first generation IPL systems that are being sold to doctors and they're saying, oh, this is cheaper, why don't you get this system? That's the big problem. You're getting a varied degree of energy every time you use that system. And this just shows the maintenance of the energy level per pulse. So this is my protocol. I will do 2 passes on the upper lid with the small Darwin tip, and then I will do trachea to trachea 2 passes. And again, this is a protocol that I established with 5 years of research and I've been using for 20 years. Internal, external shields. This is a question I get all the time. So here's what we found with confocal microscopy. If you use internal shields, you're going to be causing inflammation on the cornea. The internal shields do not give you any added protection. What you really want to protect is wavelengths of light on an open eye. The only time IPL has shown a problem is shooting somebody with IPL and these wavelengths of light being absorbed by the iris, causing iritis, iris translumination defects. None of those patients had any retina problems. So when people say, oh, I do internal shields for added protection, it's not protecting anymore. And then the other thing I tell them is you're actually depriving your patients of these wavelengths of light that actually stimulate the retina to work better. So if you don't understand photobiomodulation and you don't understand why these wavelengths of light are important, you're going to use an internal shield. But it's going to cause problems. One thing that I've seen recently with people who are using internal shields is ptosis, lid ptosis. They'll do IPL, they'll put an internal shield. Right after they do IPL, the patient will have 1 to 2 millimeter lid ptosis. So you do not need internal shields. An external shield covering the eyelashes, because IPL used to be a treatment for hair removal. So you want to cover the eyelashes. You want to expose the meibomian glands so these wavelengths of light can go to the meibomian glands. So use an external shield. People call me and say, hey, I found this IPL system in my garage. Do I just use the same parameters that I read in one of your papers? I'm like, no. So each IPL system is different. All their numbers are going to be different. Each IPL system has its own protocol and its own parameters. So don't think a parameter for one IPL system will work in this IPL system. So I do 2 IPL treatments before surgery. So one treatment, and actually with these newer IPL systems like the Darwin, you could do an IPL treatment, wait a week, do an IPL treatment express, wait a week, IPL express, and then you can book them for surgery. So you really do not have to wait a long time to optimize the ocular surface before surgery. Chalazion, hordeolums, and styes. This is where that little footprint on the IPL works very, very well. Instead of doing a surgical treatment, a patient will always go through this protocol where I will do an IPL onto the chalazion. I will do gentle expression. If it's a hot chalazion, they're only going to let you push so hard. So I do a little gentle expression, try to get the flow going up, hit them with a steroid antibiotic. I have them come back in 3 to 4 days, and we do it again. So like say they come in on a Monday, I'll probably hit them again like on a Thursday or Friday. And usually in a majority of these patients, IPL can take care of a chalazion or a stye. And then on another note, photobiomodulation, just like low-level light treatments being used for age-related macular degeneration, I developed and patented a treatment using low-level light, red light, and infrared to the meibomian glands. This generates about 1/3 the energy of an IPL. It's safe to use at home. They don't have to use any kind of eye shield. These wavelengths of light, it's an LED, so it's not going to hurt their eyes. This is something that they can use at home to keep these meibomian glands working and to give stimulation to the mitochondria for the cells to work. And then IPL, and this is how I discovered it in the first place. I was using it for rosacea and photofacials. IPL system can be used for a variety of things. It can be used for facial rejuvenation. It could be used to get rid of brown spots. It could be used in acne, rosacea. This is something I had 3 teenage girls. They're all older now, but to get them to do their homework and to clean dishes and to clean their room. If they wanted treatment for their acne, they'd want IPL, and I'd say, if you want your IPL treatment, you're going to have to clean your room. They'd be like, ah. So great way to get teenagers to do what you want. Get an IPL system. So rosacea, acne. So if you want to see more of this, we have a Saturday clinic in New York City where you can see us treat patients, get training on IPL, get training on the keratograph, and just kind of know our system on how we treat patients for dry eye.